This is really the Israeli experience about inherited predisposition and what is beyond BRCA1 and BRCA2. And as you know, if we look, this is just, I'm a consultant to Teva and also to the Phoenix Insurance Agency. But we're talking about a minority of the cases. We're talking about maybe 5, maybe 10% of all cancer cases that you will see throughout your careers as oncologists, as primary care physicians, as anything in the medical profession. You're not talking about a very common disorder. You're talking about a very, very uncommon disorder. And when we look at the gamut of cancer, regardless of the type of cancer, be it breast cancer, ovarian cancer, or anything, but I'm using this lovely slide that I stole from the ASCO a few years ago. The majority of cases, if you ask the question, is there any cancer in your family, the answer would be no. So 80%, 75 to 80% of individuals, even upon rigorous asking, is there any other individual in your family with breast cancer? The answer is no. About 15, maybe 20% was, yeah, there's some, my distant aunt, my father's sister's cousin had breast cancer in addition to me. So there's some sort of a familial clustering, and in all honesty, we really don't know what the genes that drive this familial clustering, which is not a monogenic disorder. And a very minority of the cases would fit into inherited predisposition to breast cancer, which is a monogenic disorder. And just based on the family history, this is a very famous slide from Klaus et al. In 1994, so 20 years ago. If you take meticulous family history, you can actually assign risk for developing breast cancer simply by taking the family history. So this individual here, who has a second-degree relative, an aunt or a grandmother, who developed breast cancer above the age of 70, even though theoretically and from the syntax point of view, it is family history of breast cancer, her risk for developing breast cancer is similar to that of the general population. Whereas this individual, on the other hand, who has 2 first-degree relatives, who've both developed breast cancer under the age of 30, just based on that particular item in her family history, her risk for developing breast cancer is close to 50%. So family history is really, really important, especially in countries where, you have a family history, not like our country, which is an immigrant country, 66 years, have undergone the Holocaust, and life expectancy in Iraq and Northern Africa was about 40 years at the turn of the 20th century. So in some cases, very rare cases, you see families where you have 4 cases in 3 generations of breast cancer, ovarian cancer, and pancreatic cancer. And this is what you refer to as a classical BRCA2 family. And here you have a family, again, with primarily breast and ovarian cancer, early age of onset, and a monogenic disorder. And this is a classical BRCA1 family. So clearly, the family history alone can guide you, but it's insufficient. We need some sort of a genotype. We need some sort of an objective testing to assess the cancer risk in our families that come to us, and in women who are not affected but have a multitude of breast cancer and other cancer cases in their family. So if we look at families where we have a variety of cancer, breast and ovarian cancer, literally 75, maybe 80% of those families are accounted for by mutations in BRCA1 and BRCA2. So the presence or absence of ovarian cancer, even a single case in the family, really makes a difference. Only about 30% of families where you have many, many generations and early onset of breast cancer, but not even a single case of ovarian cancer, only 30% are accounted for by germline mutations in BRCA1 and BRCA2, which means, hey, there are other genes out there, and maybe more than one. So the BRCA1 was first published in October of 1994, BRCA2, depending who you believe in, late 1995 or early 1996. And overall, in the current data sets, there are about 3,500, maybe 4,000 pathogenic mutations. I'm not talking about variants of unknown significance or simple SNPs or even silent mutations. I'm talking about 3,500 pathogenic mutations. Overall, in the Jewish population worldwide, again, in the published data sets, there are only about 100 mutations. Of those 100 mutations, only 12 were found in more than 2 families. So, and we call them either the predominant mutations or the recurring mutations. And each one has his or her own story. So if the general Rabbanut in Israel would devise a test to determine who is an Ashkenazi Jew, this would be the prime target. anybody who has this mutation, the 6174 del T, is by law or genetically is an Ashkenazi Jew. And I have two Bulgarian families who really, really didn't like the assignment of being branded as Ashkenazi. This mutation, 5382NC, is actually not even a Jewish mutation. It's a mutation that is very prevalent in Latvia and Lithuania. It started in the Baltic Sea about 1,200 years ago. And it started in Scandinavia about 1,800 years ago. And through migration, through Cossacks and pogroms, it has been inserted into the Jewish population. This mutation is a very interesting mutation because we thought it's an ancient Jewish mutation that is detected in Ashkenazim and in non-Ashkenazim. In fact, it's a mutation that started in about 1,200 years ago in the Ashkenazi population, and through back migration, it came back to Iraq about 500 years ago and about 600 years ago, right around the time that Columbus discovered the New World. It has migrated to the New World, and it can be found, it is the most common mutation in BRCA1 in Spanish non-Jewish individuals who reside in the San Francisco Bay Area. One more reason to move to the Bay Area. This mutation is a mutation that we find in a few Yemenite families. And it is the most common mutation in Sardinian individuals of non-Jewish heritage. So we thought, hey, Sardinians may be one of the lost 10 tribes, and they share a haplotype with the Yemenites. But it turns out to be a totally different origin, a totally different haplotype. So no, the Yemenites and the Sardinians are not one and the same. But the fact that we have only a limited panel of gene mutations that can be detected easily and less expensively than what Myriad has charged until a few years ago enable us to do several studies that have come up that make our life a lot easier. So if you look at the Jewish Ashkenazi individuals, not a personal or a family history of breast or ovarian cancer, 2.5%, or 1 in 40 Ashkenazi individuals, and 1 in 200 Iraqi Jewish individuals carries one of the 3 predominant mutations in Israel. If a Jewish Ashkenazi woman has ovarian cancer, just by that fact, she has a 35% of having a BRCA1 mutation, and if she has developed ovarian cancer under the age of 50, it's 40%. So these numbers are unheard of anywhere else in the world. Just to give you an example, 1 in 40 in the Ashkenazi population. In the United States, the numbers are anywhere between 1 in 800 to 1 in 1,300 in the general population. So we can translate this, and we can take advantage of it and actually look at the penetrance and maybe offer genetic testing to everyone who is an Ashkenazi Jew, or at the minimum, in my opinion, anybody who had ovarian cancer and breast cancer and their first-degree relatives. And I think it's a very interesting perspective. And there is a recent paper in PNAS, which is through the Israeli Consortium of Inherited Breast Cancer, showing that the penetrance in the general population is the same as it is in high-risk families, which means family history matters very little in terms of penetrance of these predominant mutations in the Jewish population, and about 30% of individuals who tested positive had absolutely no family history of breast cancer. So, continue the theme that we heard before, if we find it, not that they will come, if we look for it, we will find more mutations in individuals who are at extremely high risk and they don't even know it. So, when a woman comes to us and says, my brother had breast cancer, my mother had ovarian cancer, my uncle had breast cancer, my grandmother, nobody talks about it, but we know she had breast cancer, and her sister, God forbid, had ovarian cancer, we look for the predominant mutations. We don't find it. So what do? We do full sequence. Initially, we did full sequence of BRCA1 and BRCA2 on those individuals. And if you look, so what are the chances of finding a private mutation in these individuals who are of Ashkenazi origin? And again, we did Ashkenazi because A, the disease is more prevalent, and B, most of the studies that emanated from the United States where there's an overwhelming presence of Ashkenazi Jews in the Jewish population. So the numbers are really, really strikingly similar. So it's about close to 5% of Jewish Ashkenazi individuals who do not harbor any of the predominant mutations in BRCA1, BRCA2. When you do full sequencing, you will find a private mutation. So in essence, when someone comes to us and says, well, I'm not happy, I don't have a mutation, should I continue the genetic testing? My immediate response is, It's a matter of finances. If you are willing to sacrifice X amount of shekels or dollars or rubles or euros for a 5% chance of finding a private mutation, then it's worth your while. So I want to stress the significance of detecting and testing an individual who was affected with cancer. So this individual, she tests negative for a BRCA1 mutation. She's an Ashkenazi Jew, but nobody in the family who was affected with the disease has been tested. This individual, despite the fact she does not carry a BRCA1 or a BRCA2 mutation, is still at a high risk because the risk is derived from the family history. And you can use any algorithm that you want. Her risk for developing breast and ovarian cancer is far and beyond that of the general population. However, this individual who tests negative and her aunt who developed ovarian cancer is positive is a true negative. And despite the flurry of some articles and studies in the late 2007, 2008, her risk for developing breast and ovarian cancer is identical to that of the general population, and she does not need to undergo strict surveillance. And sometimes these women say, well, but I want to do it. I said, you know, you can do it. You don't have to, but if it makes you feel more comfortable and you're willing to go into the MRI machine every year, go ahead and do it. Be my guest. But she needs to know she's not at a high risk because she's a true negative. And this is something that we should know. So the first order of business, we test for the common mutations. And right now, over the last 2 years, we've been using a panel of 14 mutations, the 12 mutations that have been detected in more than 2 families in Israel. We added on, just for good measure, the mutations that have been found in Russian non-Jewish individuals and in Polish individuals. We added 2 mutations, one that we detected with Professor Zidan in the Muslim and another one in the Druze population. We haven't found any surprises there. So we do a panel of 14 mutations, and then it's a decision point. Should we do full sequencing of BRCA1 and BRCA2? And if we do full sequencing of BRCA1 and BRCA2, and the family history looks just like that, then we go on and do a gene panel. Right now, initially, this is the same slide from, I think it's the same study, showing what is the contribution, the relative contribution of those additional high penetrance and moderate penetrance genes, BARD1, BRCA1, CHEK2, NBN, PALB2, RAT50, RAT51C, P53, to the overall burden of inherited predisposition to breast ovarian cancer in world populations. And this is the same study, and we can see that even though the overwhelming majority is BRCA1 and BRCA2, there's a subset which includes other mutations. And this next slide shows you the results of some of my students, my past students, who've looked at CHEK2, very few mutations, BRCA1, very few mutations, P53, no novel mutations, P10, nothing, PALB2, RAT51C, and the list goes on and on. So seemingly, based on these past studies that were conducted, all of them, or mostly on Jewish Ashkenazi high-risk individuals who did not have any of the predominant mutations or any sequence alterations in BRCA1, BRCA2, it seems that the contribution of these additional moderate or high penetrant genes to the overall burden in Jewish individuals is minimal at best. Again, these studies are predominantly done on Ashkenazi Jewish individuals. So this slide was done in a research context. It was done, so the early studies from 2002, we used DGGE, for those guys who still remember. Later, we graduated to using Sanger sequencing. Hip, hip. So how do we deal with these individuals on a clinical basis? Obviously, we do the cancer gene panels, and we've been doing that since February of 2013. And I just want to give you a glimpse of what we've done so far. So about 200 samples were genotyped from a variety of individuals, some of them in this room, some of them are not in this room. And all these individuals were affected fit into the commonly used criteria for high-risk family. And they were all affected with cancer, be it breast, ovarian, pancreatic, or any other cancer, and none of them carried the BRCA predominant mutations. This is still not covered by the health basket, which I hope will change. So just to give you a taste of our positive results, so this individual is of Libyan Turkish origin. She developed breast cancer at age 43. The family history is noted for a mother, a maternal grandmother, sister with breast cancer between the ages of 40 and 55. The maternal grandmother sister had ovarian cancer, and the paternal aunt had breast cancer in 70. So it comes from two sides, and obviously the result is a pathogenic BRCA2 mutation, and the outcome is that she had risk-reducing oophorectomy and testing of her sister, which is a non-carrier of this mutation, and the maternal aunts. So this is actionable. We do the testing, we can assign a risk to it. She needs to undergo risk-reducing oophorectomy, and her sister got tested, and despite the fact that her sister was part of that family, she did not need to undergo risk-reducing oophorectomy, and her children are off the hook again. So this is another family where you have Lynch syndrome, clearly Lynch syndrome on the paternal side, endometrial cancer at age 42, colorectal cancer at age 52, and ovarian cancer at age 50. But on the maternal side, it seems like, it's BRCA, breast cancer at 56 and ovarian cancer at 48, and she carries a pathogenic mutation in MSH2 and no BRCA mutation. So she fits into the criteria of Lynch syndrome, both clinically, and now we have the proof, genotypically as well. Is she not a high risk for developing breast cancer? Well, certainly she is. Is she at a high risk for developing ovarian cancer? For sure, both on the paternal side and because she's a carrier, and on the maternal side. So this just shows that using this gene panel, we can dissect out. She has a mutation on her paternal side, but she's still at a high risk for developing breast cancer because of her maternal history. This is a very interesting case, and this woman was diagnosed with triple-negative breast cancer at age 43 and on one of her breasts. Her family history was noted for a mother who developed breast cancer at 43, a maternal grandfather and two of his sisters who developed breast cancer, and he's developed some sort of tumor at age 70. Her father developed a central nervous system, a CNS tumor at age 58, and her paternal aunt developed ovarian cancer. So this is clearly a breast cancer family, or a cancer predisposition family. So she was tested for using BRCA sequence, full sequencing, and it was normal. And looking at the tumor, using the Foundation One or Foundation Medicine, 47% of her tumor cells contain a mutation, which is clearly deleterious in BRCA1. And using InVitae, we looked at peripheral blood lymphocytes, at buccal smear, and at the contralateral breast, the phenotypically and histopathologically normal breast. So 3 different tissues from the same individual, and we have about a 5% rate of the same mutation using next generation sequencing. And just to remind you, that mutation was looked for in using Sanger sequencing, and we did not detect it. The mother was also tested, and she did not harbor any of the mutation in her peripheral blood DNA or buccal smear using next-generation sequencing. So this is the first case of low-level multi-tissue mosaicism in that individual, and that just shows the small peak. And some of us may disregard it as background noise, but it's not. It is truly low-level mosaicism and has never been described in BRCA1, and we're eager to publish it. And we have the feeling that it may be a more general phenomenon. In early onset breast cancer with triple-negative who had a rapid clinical course. This individual died within 15 months of a very, very aggressive disease, which spread to the lungs, to the brain, to the bones, and she died within 15 months of the initial diagnosis. So this is low-level mosaicism is not only for quote-unquote common genetic disorders, it may also exist in BRCA1 and cancer predisposition genes. So overall, we have 205 cases that we've submitted and sent and used InVitae. 16 of them, or 7.8%, contain a pathogenic BRCA or RAD51C mutations, which have led to recommending risk-reducing oophorectomy. We have 10 novel BRCA mutations, and in Jewish individuals, there are no gene rearrangements using or CNV abnormalities. We have one in a Christian Arab, an incidental finding on MSH6 and a RET mutation. And obviously, as you know, RET is associated with multiple endocrine neoplasia type 2, and their recommendation for an MEN2 case is not only to screen, but undergo prophylactic thyroidectomy, because they're at a very high risk for developing medullary thyroid carcinoma, which, although can be detected, it does not respond to anything but surgery, and no chemotherapy, no radiotherapy, no iodine, radioactive iodine. So you have a RET mutation, which is pathogenic. You submit the patient to risk reducing or actually prophylactic thyroidectomy. Notably, in our population, of the 205 individuals, again, all of them are at high risk. There are no PALB2 mutations, no RAT50, no NBN, no BRCA1, and all the other genes have very few VUSs. I've listed here that there are 48 VUSs, but most of them we know are sequence variants. They are not variants of unknown significance. There is about 4% of VUSs in those genes, and we are, and the good people in InVitae are still working feverishly to decipher what is the significance of them. And one of the things that I'm really, really happy about is the ability to do cross-aggregation analysis, and using that old tool to really decipher and assign a pathogenicity or a non-pathogenicity to any variants of unknown significance. And the situation in Israel, as you're all aware of, is that patients and their family members are very accessible, and they love to participate in these studies, especially when they stand to gain. So we've gone from stage 1, where we do just the predominant mutations based on the clinical phenotype. We don't find the predominant mutations. The next order of business, the reflex, is to do full sequence of BRCA1 and BRCA2. We still don't have a clue what is going on in families like this. The third order of business, or we jack it up a notch, and we use the cancer gene panels. We still don't get anything. So the next order of business is to do exome sequencing. And this is an ongoing study, and we have some extremely, extremely exciting news. And this study was sponsored by the Israeli Cancer Association and the Italian government, and we have exciting news which I hope to share with you next time we meet. Thank you very much. Oh, thank you very much. Which is everybody's going home. No questions? No answers?
So Eitan,
Yeah.
too complicated. It's interesting that you had no findings in the genes that you mentioned. But again, if the experience in the other countries were to be relevant to Israel, you would have only expected 1%, which in 200 patients needs 2, and the chance of seeing 0 if you expect 2 is actually pretty high. How big a study do you think we need to do to really understand the prevalence of these mutations in cancer patients in Israel?
Just off the top of my head, 2,000. 2,000 is a good number. And there has to be an equal representation of all the ethnicities in Israel, Jews and non-Jews alike. Otherwise, we can't make any statements. But for Ashkenazi individuals, based on our experience, I think the Ashkenazi individuals should be forewarned. The chances of finding additional gene mutations is low, and it's minimal at best, okay? But for the other populations, I can't make that statement. Yes?
Your cohort, what is the statistics regarding de novo mutations?
Well, to say that it's a de novo mutation, we actually need a trio design. And I don't have that design. So if I find the de novo mutation in that particular, in the individual, the YS individual that presented, it's probably a de novo mutation. There are 9 manuscripts describing de novo mutations in BRCA1 and BRCA2 associated with a variety of phenotypes. In other cancer genes, it's up to 50% in neurofibromatosis. I don't really know, but the study designed to be doing that is actually to look consecutively in all individuals who have a BRCA mutations and try to define what is the rate of de novo mutations, testing in a trio. That has never been done in Israel to the best of my knowledge.